All right, thanks, Rob. Let's see. So before I start, I want to thank Sharon Leonard from the Ohio Department of Health Newborn Screening Lab for providing the data and slides that I'll be presenting today. Next slide. So in Ohio, conditions are generally added to the newborn screen after recommendation by the Ohio Newborn Screening Advisory Council. And then that recommendation is approved by the Director of Health, if the Director of Health agrees. Ohio is not bound to follow the RUSP, but the Advisory Council is required to review a condition within 6 months of its addition to the RUSP. And then the Advisory Council decides whether or not it would seem like a test that Ohio should run. The minimum time from council recommendation to a condition being added legally to the screen is 6 months, but as we'll talk later, oftentimes it is much longer than that. Next slide. So Cabe was added to the Ohio screen by legislative action with a go-live date of July 1st, 2016. The legislation allows parents to opt out of this one test, and the legislation also prohibited second-tier testing. That prohibition for second-tier testing was removed, though, from the law in 2019, but for several reasons that I'll briefly go into, we are not yet doing a second-tier test. Next. MPS1 and Pompeii were added along with Craba, but became officially part of the reported out screen in 2017. Next slide. So we use tandem aspect only for enzyme activity, and based on about 3.5 years worth of screening results, just a little over 500,000 babies, we are utilizing a hard cutoff of enzyme activity, and that cutoff was decreased last year to improve our specificity. Our cutoff is approximately 10% of the population mean, depending on the season, with lower activity levels during the summer. Our true cases, though, were less than 8% of the daily mean. We've had 7 cases. The last was confirmed in 2018, so it's been a few years. 2 of those were early infantile onset, and those 2 patients were transplanted at Nationwide, and the others were considered later onset. Next slide. So if we have an abnormal result, the test is repeated in duplicate. If the retest doesn't agree with the initial, we rerun it again. And then we also look at the activity of all 3 lysosomal enzymes, and if all 3 are low, then we do request a new specimen. Next. In general, parents are allowed to refuse the entire newborn screen for religious reasons, a religious opt-out, but for Craba specifically, they can basically line item veto that one test. That's the only disease-specific opt-out that is allowed. We have had pretty stably over the last few years about a 1.5% opt-out rate for Craba. And the refusal data is not very detailed, but it does not seem to cluster in specific counties. And throughout Ohio, as in most other states, there are areas of concentrated urban population, rural areas, and we have a significant Amish population. And the refusal rate is fairly equal among those different counties. Next slide. When we collect our screens, generally within 48 hours of birth, those are overnight couriered to the lab, and most of our samples do arrive at our state lab within 48 hours of collection. Low risk results are reported out on average in 3 days. Elevated risk results are reported in an average of 5 days, because if there is an abnormal result, that is repeated, so that takes an extra day or 2. Abnormal results are then called by the lab to the primary care doctor and to the specialty center in the patient's region of the state. The Department of Health does not call the family. Next slide. As far as follow-up goes, our newborn screening lab conducts only short-term follow-up. So we have public health nurses in the lab that contact the PCPs or the specialty centers to try to obtain what the patient's final diagnosis was and any confirmatory lab results. But this follow-up is only conducted up to a year of age. So if there is not a diagnosis by the time the child's a year old, the Department of Health stops their follow-up activity for that case and it's closed. Next slide. So next we'll go into each specific lysosomal storage disorder. For Craba, we've been screening for 5 years now. We've had close to 700,000 screens representing a little bit fewer actual unique newborns because some babies get more than one screen. We've had about a 1.4% opt-out rate, and we've had 347 screens that indicated there was elevated risk for Craba. Next slide. Of those 347 screens, they represent 341 unique babies. Of those babies, 33 were lost to follow-up, 9 have a diagnosis still pending, and 299 received a diagnosis. Of those infants, we had 2 that were confirmed to have early infantile Craba disease, which resulted in a positive predictive value of 0.67%. Next slide. Of our final diagnoses, the vast majority were either unaffected, carriers, or pseudodeficiency patients with, and you can see the numbers on the right there of 9 possible late onset patients and 2 confirmed early infantile patients. Next slide. Moving on to MPS 1, we had a diagnosis pending in 8 patients of the 153 that screened positive, with a confirmed Hurler syndrome diagnosis in 4 of those patients, resulting in a positive predictive value of 2.9%. Next slide. Of our positive screens for MPS 1, this is how they divide out, with the vast majority that screen positive having a pseudodeficiency allele. Next slide. For Pompeii disease, we've been screening for nearly 4 years. We've had 47 babies screen positive, excuse me, 47 patients screen positive for Pompeii. Of those, 4 diagnoses are still pending. 21 have possible late onset Pompeii, 4 have possible early onset but non-classic, and 4 have confirmed classic early infantile. So the positive predictive value for our Pompeii screen regarding early infantile Pompeii is 9.5%. Next slide. And those positive screens play out like this. So the majority of positive screens are at risk of later onset disease, but still quite a few of our positive screens end up being unaffected. Next slide. So just comparing Craba, MPS 1, and Pompeii, our positive predictive value for early infantile Craba or any variant of Craba is pretty low because we are relying just on the enzyme activity and because of the large percent of our population with pseudodeficiency alleles. Hurler syndrome is better for its positive predictive value. Pompeii is quite good, with 69% of our positive predictive value for any variant of Pompeii. Next slide. I'll also talk a little bit about ALD. Next. So it was added to the Ohio, so the Advisory Council in Ohio recommended that it be added to the newborn screening panel in Ohio in 2017, and it was approved by the Director of Health. There were a lot of obstacles in our way for adding ALD to the actual panel, including equipment, personnel, and of course, COVID slowed everything down for everyone. Next. But we do have a go live deadline of February of 2022. So it is around the corner. Next. The validation phase has run 7,200 samples and did not identify any positives, but there was a staff training where they pulled a few hundred extra samples to run. Next slide. And we did identify one boy with ALD when those extra few hundred were run. And so I think, at least to me, having seen that family and following that boy who's doing well right now, it really illustrates the urgency for all of us to be screening for ALD. Next slide. So some issues to consider moving forward for Ohio and possibly for other states. Next. If EIKD or early infantile Craba is added to the RUSP, we'll be able to look at the possibility of removing the parental single test opt-out. But because that is state-specific legislation, there'll be several steps to that conversation. Next. We are still looking forward to adding a second-tier test for Craba disease, which would be psychosine most likely. And once we have ALD up and running, then that would facilitate adding psychosine, but still that is a little ways away. Next. And then addition of ALD has really been a long process, but it's just around the corner, and we're all very excited about that in Ohio. So thank you, Rob, and thank you to everyone at Hunter's Hope for